Okay, sounds good. Thank you, Dr. Bora again. So I will go briefly over the STDs, any changes in the guidance, and anything new in Fresno. This is a slide mainly to tell you about the significant. I'm sure most of the providers know about this, but the STDs usually either viruses, protozoal infections, or bacteria. But the big 8 pathogens that usually we're concerned about, either they're bacteria, syphilis, gonorrhea, and chlamydia, and these are treatable, or the big 4, these are mainly viral infections that they don't have any cure because either they are DNA viruses, and a DNA virus mainly is a virus that integrates in the genome, the human genome. So it will be almost impossible to eradicate it. You could treat the acute infection or suppress the acute infection, but it tends to relapse since it's integrated in the human genome. These are 3 DNA viruses: the hepatitis B, herpes simplex virus, and the HPV, human papilloma viruses, or it's what I call it, it's a fake RNA virus, which is the HIV virus. It's an RNA virus that behaves like a DNA virus. So it converts to a DNA with a special enzyme, and from there it becomes similar to the other DNA viruses. So STD all over the world has been a major problem, a major public health problem. Just by looking at these numbers, STDs have been on the rise for the last several years globally. Most importantly, just to take from these numbers that although most of these STDs tend to be benign in the sense they make you sick, they make your partner sick, they might affect the baby, but the impact that comes in from these chronic infections, especially the viral one, is definitely on the rise. So this is a slide about the incubation period for most of these infections. You could see some of these, you could just have sex with somebody, and after a few days, you could get infected or show symptoms of infection. But some of these also, it takes several weeks, if not sometimes months, to exhibit signs of infection or to become infected. In the United States, also following the global trend, the number of cases has been just outrageous. You could see the chlamydia by far is the most reported communicable diseases. Doesn't mean it's the most common STD. Human papilloma virus by far is number 1. But if you're gonna talk about reportable diseases, chlamydia is way up there. This is also similar to the previous slide, that if you look at the financial or the impact about how much money spent on this, $16 billion are spent annually on treating or fighting these STDs. And if you wanna break these numbers down, you know, as you know, most of the money is going for HIV. It's a chronic infection. It's something that there's no cure for. You're dealing not just with the virus itself, you're dealing also with other infections or a health problem that comes from the virus. So from the 16 billion, you're looking for about $14 billion spent on HIV infections. HPV, mainly looking for the cancers that comes with it, cervical cancer and oropharyngeal cancers. If you look at the other bacterial infections, and most of them are way below the numbers that HIV has, but you have to keep in mind that although these bacterial infection has lower costs compared to the HIV, they become the next entry for the HIV for those people keep getting infected with it. I'll be talking a little bit more about the drug-resistant gonorrhea. And drug-resistant gonorrhea has been a major impact globally, and here in our county, it's one also has been on the rise lately. gonorrhea is an old infection. So if you look at some scripts from either the Bible or an old scripts from Hippocrates or Galen in the old days, it's all points to gonorrheal infection. Gonorrhea, as some of you know, it's a Latin word, gono meaning the seed, and rhea meaning a flow. And in the old days, ironically, these patients infected with gonorrhea considered to be very fertile. So for some time, it's considered to be a semen that just people cannot have any control over it. In the 16th century in France, it was named the Les Clapiers. Now, if you go to Paris, there's some districts there still named by that one. This is kind of where the prostitutes and sex workers used to live in the old days. And it was a known fact that anyone who goes to have sex or lives in that area, they're infected with the disease. And it's also, if you look at the historic scripts from the description of the diseases and so forth, some of these battles, MSMs, and it's not something new, right? So in the old days with big armies invading other countries and so forth, reports of diseases similar to the gonorrhea and chlamydia has maybe some impact about who's losing and who's winning. But the Roman armies for some time has these outbreaks, at least what's described as gonorrheal infection. And if there's any urologist in the on this conference, you should be kind of blessed now to know that the treatment is not as bad as it was before. So for some time, if you have gonorrhea or urethritis or some infection, vaginitis, the treatment was just simply barbaric, where you just have this catheter and you either inject some hot water, and the water they used to inject for centuries, it was mainly a water that you keep injecting until the person who's infected is not able to take it anymore. And at that time, they stop and they will kind of conclude that the infection has been cured. And then they switch from that to mercury. So for in the late 19th century, mercury was one of these kind of remedies. Of course, this has some, although maybe it didn't work, but it has some big impact, at least for the person who got infected, not to have sex again for the rest of his life. Gonorrhea and Neisseriae, it comes mainly, it's named after German scientist Albert Neisser. He's the same guy who's also leprosy with another guy called Hansen. So leprosy is named after it's Hansen disease, named after the other guy. And he and Neisser are the two scientists that discovered leprosy bacteria. And Neisseria is named after him regarding the gonorrhea. So during the impact in the last year of the COVID infection, you could see if we look at the cases reported, chlamydia and gonorrhea are lab-reported disease. So given the massive number of cases, any case that's positive, it's reported to the public health departments all over the country. So tracking these numbers, you could see when the stay-at-home order in California on March 19th, there has been a big drop for several months afterwards. Of course, the number slightly was creeping back. And if you look at the chlamydia distribution here in California, you could see that, as expected, the majority of the patients infected are mainly young patients. So they're in their 20s and 30s. Large number of these, similar to what we see with COVID, the inequity and so forth, led to minorities mainly and ethnic groups to be, especially Hispanic, to be majorly impacted with chlamydia. The same thing with gonorrhea. So although the bounce back in gonorrheal cases has been much higher, so you could see there has been a big drop after the home order, and then it came back with full force. Kind of the same version of the demographic and the age group. So this is mainly sexually active disease, young patients, young adults. Majority of these patients also Hispanic and Black. This is mainly a testing volume from Quest. So Quest, if you look at the number of the gonorrheal testing that has been done, regardless if it's positive or negative, you could see the total number of the specimens submitted for testing dropped significantly. So that, again, by looking at the previous slide, doesn't mean like the STDs has been down. That means because most of the clinics or hospitals or elective intervention has been postponed or halted. So the number of testing has been significantly down. And that's the reason it's kind of a fake decline or decrease in the numbers. So why gonorrhea? It's very important. I look at these, so the CDC classified these public health infections under two major categories when it comes to public health impact. One of them, they call it urgent threats, and these will involve mainly 5 different infections. Majority of these infections, you could tell from the list, are mainly a hospital or inpatient kind of infections. So if you look at the CRE, carbapenemase resistant Acinetobacter, most of the time you don't deal with this out of the hospital, or the diagnosis at least is made in inpatient setting. The same thing with Candida auris, which is a resistant Candida infection that we start seeing in California. The C. diff also, and the CRE for enterics. So these 4, in my mind, I still think that gonorrhea it has the highest impact on society for a few reasons. If you work in a hospital setting, you probably aware how many committees and infection control personnel and so forth are tracking these 4 upper cases and making kind of all kind of efforts and staff and financial support to limit the impact and putting the patient in isolation and so forth. On the other hand, gonorrhea is a little bit unique because it's never been a hospital infection or inpatient acquired infection. And it's very difficult, if impossible, to contain the extent of infection. It's also understandable that gonorrhea is not fatal compared to the other 4. But here you're looking for a highly contagious infection that's usually harder to treat, not because the antibiotics are not working, but because the person who has the infection, usually it's hard to treat because of lifestyle and so forth. And more importantly than that, that the sexual partner for these gonorrheal patients tend to be asymptomatic. And if you don't treat them because they're not sick, there's very likely they will not be seeking medical care. So the same, this is kind of a same slide to the other slide. And so the urgent threats are the upper 5 discussed, and you have the serious threats that related to other infection like VRE or Salmonella, drug-resistant TB. So any kind of infection or bacteria that has developed resistance to certain antibiotic or traditional classic antibiotic treatment now is considered to be a serious threat, but not as bad as the urgent threat. So gonorrhea, if you look at the trend here over time, which is mainly you're testing the antibiotic since the antibiotics started. So you could see in the 1980s for a few decades, penicillin was like any other infection. We start with the penicillins and sulfa drugs and so forth. But you could see over time, these antibiotics become a problem. And when you have any bacterial infection, the antibiotic resistance, it happens for a reason. It happens mainly because people are not taking the medicine the right way. And it happens also because if you treat somebody with penicillin today and he goes and spread the infection during the period of incubation or infectivity to another partner, and that other partner is not treated, this bacteria, like the COVID you see with the variant and so forth, it's very easy for bacteria to develop some resistance to it. So you could see that the antibiotic that used to work in the 80s and early 2000 doesn't work anymore. And for you who are curious about how do we test these bacteria, because most of the time, if you work in a hospital or a clinic, you do have a molecular testing for most of the infections, STDs, enteric bacteria, respiratory panel. Now the trend is for everybody to shift to molecular testing. So a culture or a susceptibility testing, usually, especially for these outpatient infections, it's usually done in a public health lab. So the GISP, the Gonorrheal Isolate Surveillance Project, similar to any other surveillance projects that it's done for influenza, it's done for salmonella, it's done for Shigella. These are mainly specific locations. Here, let's see in California, they have several of these, mainly STD clinics. And those specimens collected from those patients who are confirmed to have STD usually are done by public health lab to test them for certain antibiotics. So these antibiotics over time, you could see since the mid-1980s till now, the antibiotic have been tested for gonorrhea has shifted significantly. And now you're looking mainly for a third generation cephalosporins, which is ceftriaxone. You see most of the isolates recently tested for this drug because the other drugs are become not useful anymore. This will give you kind of a resistant trend of any bacteria over time from testing these isolates. And this is kind of the, again, this is phenotypic. You're testing a culture and you're testing the antibiotic resistant to it. And if you look at azithromycin, which is a drug that has been for the last few years recommended as a dual therapy for gonorrheal infection, there has been some concerning resistance for the recent isolates for azithromycin. In addition to this acquired or increasing resistance to antibiotic, gonorrhea become also, we know for a long time that gonorrhea is not simply just limited to the entry bodily fluids. So it's not just urethritis or cervical infection and so forth. It could spread like syphilis to the bloodstream. And this is what we start seeing recently, especially in Fresno. Although this is not a new disease, it has been reported in other counties, but at least this year, we had few cases of disseminated gonorrheal infection. That means that the bacteria, instead of just being localized or inoculated in the anal, oral, or mucosal areas, now it's spreading to the bloodstream, and from there it goes to other organs. So this is a case recently, one of the cases here in Fresno that we had for disseminated gonorrheal infection a few months ago. It's just to give you a description of how these cases are presented. So everybody kind of put that on the back of their mind that this could be in the differential diagnosis as well. So this is a 38-year-old diabetic male who presented mainly with acute joint infection, mainly his wrist and his ankle. He did have some swelling. There was no injury. The wrist looked kind of with some septic picture. The ankle also was swollen. His numbers looked kind of high inflammatory markers. The X-ray, as usual, was negative with lack of trauma, and blood cultures were negative. It becomes a problem with the smaller joints that to try to aspirate the joint becomes a little bit challenging. So attempted aspiration was unsuccessful. The person was denied any history of STD, and he stated that he has been married for 8 years. The urine test for chlamydia and gonorrhea was negative. Blood culture were negative. HIV, syphilis testing was negative. And then attempted aspiration again was done, and the scant amount of fluid that was aspirated was positive for Neisseriae gonorrhea. And then he ended up having, like any other septic arthritis, ended up having surgical IND with description of kind of septic joint. So this is a picture of the, you could see the significant synovitis, the whitish area in the ankle indicates effusion and infection. The same thing, so the repeated culture, this is kind of the same slide like before. When they did the operative culture, it didn't grow anything since the patient was on antibiotic, but the gram stain showed typical gram-negative diplococci. So what's DGI? So DGI is mainly they have these criteria that's listed to classification. So either it's confirmed. So this is mainly septic arthritis. It's a smaller joint. Most of the time it's your wrist, your ankle. Some patients, they have arthritis. Some patients, they have just mainly polyarthralgia, tenosynovitis. You could have a pustular rash, skin rash over the affected joint. Some patient could be bacteremic. And although gonorrhea tends to require special medium to grow it in a blood culture, but if you have significant bacteremia, a regular routine blood culture could grow the Neisseriae. And in some instances, this could go and give you like significant organ involvement of the brain or the heart. The challenging part, other than to think about gonorrhea in these young sexually active patients, to think about gonorrheal infection as part of the differential is mainly how to diagnose it. Because as in this patient, you could ask about sexual history, and it's guaranteed that many of these young patients, speaking from experience where I see sometimes these patients, usually the story they tell you, it's much different from reality, especially if you go into an emergency room and you're seeing a provider for the first time. And so most of the time, patients will not disclose the full extent of their sexual history. The labs really advised in these cases, if you're having a young patient with concerning clinical symptoms of DGI, is mainly to obtain cultures and PCRs, not just from the entry site. In this case, the urine, which is the typical test we do for gonorrhea and chlamydia, was negative. Swabs from sites, oral or rectal area, sometimes it's recommended. It might be kind of dealt with resistance, again, if somebody denies these kind of sexual behaviors. But if you have a joint that has been affected and you're aspirating the fluid, it's important that this this specimen sent for culture and a PCR. The PCR from the joint, usually it's available on most of the hospital labs, or it could be done just simply shipped to the public health lab. So it could be shipped. The problem with the cultures, most of these folks, you know, they require antibiotics. And gonorrhea, it's usually very sensitive to most of the antibiotics given in a hospital. So if you give ceftriaxone and so forth, it's unlikely that the culture will be positive. But the PCR, which is a DNA testing, it could be positive for sometimes few days to a week after even receiving antibiotics. So the DGI could present in two syndromes, arthritis dermatitis syndrome, or like in this patient, septic arthritis. And this is kind of a typical what you see. So it's kind of a pustular lesions that you see in the smaller joints, usually the fingers. Sometimes it looks like a bruised area, but most of the time, this is kind of a typical. If you see something like this in somebody in the clinic, regardless if they have joint problem or not, and the distal part of their extremities, keep gonorrhea back in the differential. So the DGI cases, disseminated gonorrhea infection, has been there. As I said, it's not something new. If you look in the last year in California, they had cases all over the counties. So ranging from as low, it sounds like every month there's a gonorrhea party there. So you had either a minimal of 1 case, or look in September, they had just 12 cases. So total of 88 cases just last year. And this is kind of going back in 2019. There have been cases also the same thing. These are either confirmed or suspected. And you could see some of these cases, most of these, let's see, the cases we had in Fresno this year, 3 cases, the specimens are usually will be analyzed by similar to what is done with COVID, for example, when you hear about the whole genome sequencing. The same thing, these bacterial infections, usually they will be tested to see if there's any link between the cases. So these are clusters of cases, mainly MSM cases, that has been in different counties. And you could see in Fresno was not listed there, but these usually when they come in clusters. So in Kern County has been probably worse than Fresno County when it comes to STDs. They had their own share of clusters of DGI over the years. Although DGI is relatively new to Fresno, but you could see they had 7 total in 2020 and 4 in 2019. And if you look at the demographics for these DGIs last year, majority of them, kind of similar to what we see with STDs, are young patients, sexually active patients. They have significant number also in Hispanic population. And surprisingly, there were more in female cases. The one we had here in Fresno, they're males. And kind of interesting thing about gonorrhea that usually females tend to be asymptomatic compared to males. So that's kind of over the years, if you look how they labeled gonorrhea in France and so forth, that sex workers, they really tend to have no signs of infection. Many times they end up with scarring and infertility and so forth, but usually females, they tend to have no symptoms compared to males, where gonorrheal infection tend to give you very bad urethritis. But with these DGIs, it looks like significant numbers of the patients were females. If you look also about the sexual orientation, mainly women with male sexual partners, about half of the cases. It's a little bit different from the other STD, that most of these folks were not homeless, but you have about a third or a little bit more, they use illicit drugs. And this is kind of important when you work a case of DGI in a clinic or in a hospital, that if you look at how these cases were diagnosed, blood cultures usually maybe in a quarter of the cases were positive. So usually this is routinely done for septic arthritis patients like this case discussed. But majority of these patients, they might have no positive culture. So it comes all the time, mainly to look for the synovial fluid. That fluid you're aspirating from the joint, in about 3/4 they will be positive. And this is again a culture and a PCR. And recently in Fresno here County sent a health alert also about the DGI, and mainly involving sport medicine, hand surgeons, sports experts, in addition to family practitioner and internal medicines. If you look at the urogenital, was 50% positive. So this case that we had was negative, but that's also one element of the diagnosis, that you're having young guy with unexplained arthritis, smaller joint. Go ahead and get a PCR of the urine. That sometimes in 50% of the cases might be positive. So as you know, the recent CDC guidelines, or brief guidelines, since they did not really have a full, you could say, guidelines for STDs. The last one was in 2015, and it's very likely changes coming this year about the treatment for gonorrhea. So for a long time, gonorrhea, for at least the last 4 years, gonorrhea was treated with dual treatment. So you're given Rocephin and azithromycin. So now the treatment for uncomplicated gonorrhea is mainly ceftriaxone only. And this is in major part because the azithromycin, there have been more and more resistant to the medication. And part of the problem with azithromycin, it's a medication that's given routinely to any minor infection, right? A Z-Pak is a popular antibiotic. So if I have somebody who's asymptomatic or mild symptoms with gonorrhea and I'm giving him Z-Pak for URI, you kind of bet that this gonorrhea that the patient maybe have symptoms from, maybe not, will become resistant. So this is kind of one reason why the gonorrhea becomes resistant to azithromycin, because azithromycin is commonly used for other infections. So the treatment, again, is one injection of ceftriaxone, assuming the patient is not overweight. If this not available, or the patient had severe allergy to ceftriaxone, then you're stuck with giving gentamicin, which most of the time is not available in an outpatient setting, and patient needs to go to either infusion center or some special clinic where they could get it. The pharyngeal gonorrhea continues to have a significant, you could say, impact to current treatment, because the treatment is only ceftriaxone, and a patient who had oropharyngeal gonorrhea will need to be tested at the 14 days after treatment. And there's few reason for this. Usually when you have oral sex and you have an infection with Neisseriae gonorrhea, there are some number of patients who they are colonized, or they carry the Neisseriae part of the oral flora, not the gonorrhea one. So when you introduce this new infection or new bacteria to your oral flora that might have Neisseriae, there becomes some sort of collaboration between the two cousins. So number one, the communicable Neisseriae that you have, it might make the eradication of gonorrhea infection in the mouth a little bit harder. And number two, the tonsils and the significant lymphatic system in the throat area makes the eradication of gonorrhea a little bit tougher than, even if the bacteria is sensitive, than if you have it in the urethra or the cervix. So any patient who had oropharyngeal gonorrhea should be tested at 10 to 14 days after the infection. Usually it's better to wait maybe a little bit rather than the 7 days, because keep in mind that you're doing a PCR testing, and PCR sometimes could be positive from dead bacteria for some time. So it's, if you want to do testing, do it at the 10 to 14 days. And all patients treated with gonorrhea, regardless if it's the entry of the site, they need to be tested again at the 3 months entry, 3 months after the infection was treated. So the only, chlamydia doesn't follow these rules. So in the old guidelines, we're waiting for the new guidelines. Usually test of cure was only recommended if you're pregnant, but most of the time there was no really test of cure. It was recommended to test at the 3 months, but the test of cure where you're testing at the 1 to 2 weeks was not recommended unless you, special circumstances. And this is also another interesting observation that they found when this study in New Zealand in 2017, that these teens who got vaccinated for Neisseria meningitidis. And as you know, the Neisseria vaccination, there are two kinds. And most of the time, especially teens going to dorms or universities, it's required for them to be vaccinated. So they found that there's a cross-reactivity for folks who got vaccinated for Neisseria meningitidis. They have lower risk of getting infected with gonorrhea because the antibodies that you develop for the Neisseria meningitidis might give you partial protection for the gonorrhea. Of course, this is all theoretic, and but it's kind of something that's worth looking for, and maybe a vaccination for the two strains of Neisseria could be in the future something that could help stopping the pandemic with the gonorrhea. So gonorrhea in Fresno County has, no surprise, it has been going up. If you look at our syphilis cases, usually our syphilis cases peaked at 2017. That never happened for the other infections. So STDs continue to be on the rise, and you see their steady trend. And if you look at the age, you still have significant number of young adults, teens, 15 to 19, almost like 15 to 20%, which is a scary number. And these are the patients probably that are harder to treat. They have probably poor insight about the infection and testing their partners and identifying their partners. So it becomes a problem. And if you look at this, who was treated for gonorrhea? These are, again, our local data. I mean, there's no question that the partners very unlikely got treated. So was the partner treated? This is mainly about partner treatment. And majority of these patients, more than half, it's unknown. That means probably not. And the other probably 45%, there was instruction to treat the partner, but it was mainly just a recommendation rather than an active step to treat the partner. And that's, again, becomes a scary thing because with gonorrhea, usually, as I said, the partners are usually, especially females, are asymptomatic, and very likely the patient, if this is not a casual sex, will get infected again by having sex with the same asymptomatic partner. If you look at the districts or the areas in Fresno County, similar to what we see with other STDs, the southwest part of Fresno is impacted more with these gonorrhea cases. So that's gonorrhea. Syphilis has been also on the rise in California, as you know, for the last decade or so. Childbearing age females and congenital syphilis has been, if you look at Fresno, has been a hot spot. So the inner part of the state, either by female infection or congenital syphilis, has been very concerning. This is kind of similar. In 2018, about 10 out of the 58 counties in California, they considered to be a high morbidity cases. And Fresno is one of the top. Most of these maternal or female cases, as you know, they have some lifestyle, unfortunately, that makes eradication or stopping the cycle from infecting the baby or having another child with the same problem challenging. Majority of these cases, they have no prenatal care. A little bit more than half of these females, they use meth. They have either homelessness or incarceration. So there's definitely unhealthy poverty and lifestyle changes.
Yeah, that's what I was going to add, Dr. Al, is, I think people don't understand meth equals syphilis and syphilis equals meth. I mean, that's a huge syndemic. And so, I think the message needs to be out there that this is a point of intervention, that we need to screen everyone who's using drugs for STIs, just because they go together so frequently. Obviously, there's a lot to say about universal screening. I know that pregnant women do get screened, but it seems like these cases still kind of fall through the cracks. So I don't know if you have any comments or insights about, how can we prevent congenital infections moving forward?
Yeah, you're absolutely right. I mean, most of the cases we see with the congenital syphilis, the moms having sex when you're high, and even afterwards. I mean, it's just several babies born with intoxication from the drugs, and repeatedly you see the same mother just having, it becomes like a poor quality movie, right? You're just seeing the same scenario again and again with different kids, either stillbirth or congenital syphilis cases. So yeah, this is absolutely, you're right.
I think the barrier, the structural barrier, and other counties have done this. They've introduced, like, they're just going to screen every single person that walks into every ER in their county. But the pushback that we get is that, once the patient leaves the clinic or the hospital or the ER, who's going to follow that person up? And that these people get lost in the cracks, and that just introduces issues of access and liability. But that's where public health, in my opinion, really needs to create that connective tissue and have navigators that can follow people up. And we do have some of those resources, but we need more done in this space. So just to give everybody some insight, we're investing in a program where, no matter which door the person walks into, public health can provide a navigator to help them close the loop, so that just because you send a test, you don't have to worry about when that test comes back positive, where is the person going to get treatment? That should not be a barrier to sending the test. And public health, I feel like it's public health's role to help fill in and get those people contacted and treated if our clinicians can take that first step of actually sending the test. Sorry to interrupt.
Okay, sounds good. And this is the same story also about, no surprise, right? The county affected with syphilis and STDs are the same county that has higher poverty and inequality rate, and Fresno also is in the center of this. Just to give you an idea about syphilis with history, since you have a little bit of history with gonorrhea. So Boeck, there are two studies that we learned about syphilis and why we have these stages. Boeck is one of them. It's a Norwegian scientist who declined treating these infected patients with syphilis with the traditional treatment at that time, which was mercury. So mainly he just followed these patients over the years, and from his description of the stages, primary, secondary, and latent, we had, but the Tuskegee, notorious Tuskegee study in New Orleans, which was, as you know, probably the one of the dark history of the CDC, where you had about 443 cases of known syphilitic patients who were observed over the years to see the natural progress of the disease. And more than half of them died. Of course, they were not offered the bicillin or penicillin treatment at that time. But why we do know too much about syphilis? Because of these two studies. Syphilis goes in stages, as I said. Most important thing is, like, if you go in the secondary stage where it's bacteremic and you don't get treated, usually people get better without treatment and they go to the latent stage. But 25% of them, they go bacteremic. So it becomes, the bacteria hides in certain areas and becomes, every once in a while, decides to go to the bloodstream and give you the same manifestation. So it's not unusual for you to see a patient who comes in with secondary syphilis, and retrospectively secondary syphilis, and they don't get treated, and down the road they go back and they didn't have any sexual encounter with anyone, and boom, they got back to the secondary stage. So there's 25% of these cases, they do have relapse. And the same story here, like it goes in several stages. And keep in mind, when you treat any patient with syphilis, you ask about neurosyphilis changes. So any patient who has unusual headache, new headache, hearing or ocular manifestation, they could be dealing with neurosyphilis, which has different treatment. Syphilis, secondary syphilis, is a bacteremic phase, similar to the gonorrhea where the DGI manifestation is there. The same thing with syphilis. It could go to different organs It could simply just have different manifestation of the skin, different rashes, or it could give you different manifestation of the internal organs. The skin of the syphilitic lesions is very unique, and I would like to, this is a real case from Fresno County where this patient was thought to have eczema or dermatitis of her, she had this rash for almost few weeks. It turned to be just very high RPR. So keep in mind, you see somebody who is sexually active, you have a rash, palms and soles, it's very likely that this person could be dealing with syphilis rash. The treatment for syphilis is long-acting penicillin. And one thing I would like to point here, that when you give intramuscular injection, unfortunately we see it sometimes with these cases that come back to us, that if you give intramuscular injection of benzathine penicillin, it should be in the buttock area. Many times we see cases done in the deltoid, and that's not acceptable way for dispensing the medication in your, this is kind of a long-acting medication. It requires a big mass muscle. So given an injection of benzathine penicillin in a smaller muscle usually will be partially effective. And some of these patients will require re-injection in the buttock area. So you can, for primary or early stages, you're gonna need one shot. Unless you're pregnant, you might get a second shot. And late at manifestation, usually you require 3 shots weekly apart. If you're allergic to doxycycline for 2 weeks or 4 weeks, if it's latent stage. If you're pregnant, only benzathine penicillin is recommended. For latent stage, as I said, 4 weeks. If you decide to give doxycycline for some of these folks, and you're gonna give them 1 month's supply of doxycycline, make sure the patient understands the importance for him to take. If you're having somebody with poor insight of their illness, the chances for them to take doxycycline for 4 weeks becomes probably not good chance to finish the treatment. Congenital syphilis is pretty significant for females who are pregnant. So if left untreated and you're having infectious stage of syphilis, 80% of these cases could lead to infection. I still remember a few years ago when the Zika arrived to Fresno and people were panicky and so forth. You know, the chances for you to get Zika to the baby compared to syphilis, it's not comparable. And it's understandable that syphilis affects certain women with poor lifestyle choices, but syphilis probably one of the most contagious infection that could be transmitted vertically. And 15% of the cases in California that recently on yearly basis, 15% of these cases are pregnant. If you look at the cases of Fresno, of the counties, you could see most of the other counties, they had males predominant infections. When you go to the inland area, you see much more females. So that's why these cases are much more, you see much more congenital syphilis cases. There are more shift for female infection compared to male infection. The same thing here about syphilis with the pandemic, that you could see the number of testing has been down during pandemic. Doesn't mean cases, actually it's expected that probably the congenital syphilis cases will rise more this year. Usually when you have more cases of primary syphilis, a year later, congenital syphilis start erupting. And this is kind of just a brief summary of the cases that we see with pregnant females with infection. Like this is a young female tested at different parts of California. The baby was infected, and the mom at the end, although she denied any kind of sexual encounter and so forth, her titer was significantly high, and the patient left AMA, and the baby was a stillbirth. So recently, the CDPH released these guidance also to try to help stopping this big flood of syphilis cases. And these are considered to be high morbidity and mortality counties. If you have more 8.4 congenital syphilis in the 100 incidence rate, then you consider to be high morbidity. So there are 5 recommendations that this is usually done here, that every pregnant female should be tested. In Fresno, it's tested 3 times upon having first prenatal encounter with the physician, and the 3rd trimester, and upon delivery. And then testing upon delivery, again, this is has been done in Fresno regardless of your risks. And as Dr. Bora just mentioned, that most of these folks, if more than 50% of these infected moms are with no prenatal care, many times the only encounter, which is kind of unfortunate, is for them to be tested before delivery. It's usually, unfortunately, in the emergency room setting. And that becomes kind of the only way for testing these females before it's too late to prevent the infection of the baby. So it's now recommended that any patient who comes into the emergency room should be a female who's pregnant. You should get a history of previous testing, if they have any, and if not, to go ahead and test them. If they have any symptoms, to treat them. If the test is not available, to at least have coordination with the public health regarding further testing. And at the end of these slides, you'll have the numbers for our STD program for follow-up these patients. The same thing at the correctional, at the jail. So every patient, females or males, for several years, everybody who comes to the jail upon intake, if you're female, less than 30, male, less than 35, or the other way around, you should be tested regardless of your sexual history of your symptoms. And in community in general, any sexually transmitted patient should be tested at least once for syphilis. If you're pregnant, testing for HIV, it's recommended. The same thing with hepatitis B. Congenital syphilis cases in California, you could see since 2012 has been significantly high. And although, again, in Fresno, we peaked in 2017, but the trend in California has been continued to go up. This is a repeated slide. 56% of the cases infected females with no prenatal care. So you're having somebody who's tested positive upon delivery, which is kind of too late to do anything about the baby. If you look at these, the counties in California, so this is in 2018, the number of the cases of primary and secondary syphilis. So this is mainly the early stages. These are the very infectious stages. Fresno ranked number 13 or 14. Back in 2017, we were like somewhere here in the middle in Kern County. So this is kind of, although our numbers here, they have been at the state number in 2018, but this was after a big struggle in the years before. And if you look at the congenital syphilis in California in 2018, Fresno was at number 4. Kern County, they still have the biggest crown actually for the last few years with the cases. So they were number 2, we're at 37, they were at 56. We did have in 2017 about 68 cases, but we're ranked number in the big 5. And congenital syphilis in California, you could see for the last decade has been going up compared even to United States. So there had been a big separation in the curve. One reason why in California syphilis has been much higher, you know, in 2000 till now, the number of cases of males, especially MSMs, have been significantly outproportioned to the females. So big difference compared to the rest of the country. And one major reason for this is social media and the internet. It's easier for you to find a sexual partner, just casual sex online. It's cheap, you could have a meet at pleasure, but that comes on the expense of catching one of these STDs. And this is a significant slide I would like usually to show that if you look at the early stages of syphilis and you look at their HIV status, 50% of them were negative, but 50% of these cases with HIV, with the syphilis, they have HIV. So that means, you know, chances for your partner to not just have syphilis, but to have your HIV significantly, it's a scary number, right? If you look at the PrEP, how many of these patients with early syphilis who are HIV negative, but who are on PrEP to prevent the HIV transmission, it's only 40%. So you're looking for 2/3 of these syphilitic confirmed syphilis cases that are not taking PrEP, but you're having significant partners who are HIV positive. The same thing here in California. I showed this, but you could see in the number of stillbirth, still also significant there. So 32 cases in California. Fresno, we're having 3 to 5 per year. This is the same kind of slide. And this is kind of where it's recommended. Not every county in California recommended to have a 3rd trimester, only the ones with the high morbidity for syphilis. So only, you could see mainly the inland counties. So Fresno has been, it has been a plague of STDs for the last several years. You could see the number has been going up, although it plateaued since 2017. But if you look at the most recent cases in 2020 and 2000, it's unofficial numbers yet, but pregnant female, they had 63 cases, 10 cases so far. This was from 2 months ago, so it's probably higher by now. So it's a scary number, right? If you look like 40 non-pregnant female positive, 10 pregnant just this year. So almost like a quarter of the cases. So I do expect that although our numbers has been plateaued since 2017, that very likely that we're gonna have a surge of the STDs this year. Congenital syphilis in Fresno has been kind of similar to the trend that we see everywhere else, that prenatal screening and the stage of the pregnancy and infection is kind of the same. Treatment in pregnancy for syphilis, again, it's only penicillin. There's no other treatment. And to give you an idea about how do we work up some baby with the mom who is positive, becomes a little bit complicated because you have to look at the mom's history. And many times you go to a provider, the patient might be in different clinics, different treatment, different testing, and you don't have access to it. So it's important, I think, when you see somebody, especially in a hospital setting with delivery and you don't have records, to call the public health to get the records of this patient, how he was treated, and the prior testing that was done. Syphilis is complicated because it's a collaboration between the physician who is treating the patients, the public health follow-up regarding the partners and prior testing and records and so forth, and surveillance that you're doing in the emergency room or in the jail setting. Congenital syphilis, it's usually, if you're just curious about how the classification surveillance-wise, there's no confirmed cases. Most of the confirmed cases are usually done when you do a PCR or dark field testing, and that's usually done in special labs and mainly done for stillbirth babies if you want to confirm on the placenta tissue. But most of these congenital syphilis cases are probable. Congenital syphilis goes in stages as well. So it goes in early symptoms, mainly mucosal cutaneous manifestation, or late where you have significant joint, ocular, and bony abnormalities. Different also clinics, the CDC has not been kind of endorsing one way of testing for screening for syphilis compared to the other, but the traditional way of screening has been to do RPR. If the RPR is positive, then you go to the trypanosome testing. And for somebody to be infected, if they have prior testing, you need twofold or 2 dilution increase and 4-fold increase in the titer to be considered to be infected. There's more shift now to do what they call it reverse sequencing, where you start with the EIA, which is a rapid testing. And if that's positive, if it's negative, then you stop. If it's positive, you go to RPR. If the RPR is negative, then you go to the trypanosome testing. This is, in my mind, is much better than the other one because you're not missing somebody who might be negative RPR, and many of those patients, especially late stage, they might have a negative RPR, a negative TPPA that you detect only with the reverse cascade. Sexual contact to syphilis in the previous 3 months should be tested, and usually you should not even, you should treat them. If you're in the clinic and you have somebody with syphilis, the partner's there, just go ahead and treat them and get the testing done, because even a negative test might be incubating and the test might be negative. This is kind of our most recent numbers for the last year. You could see we had 35 cases of congenital syphilis. This is during the COVID bad year. Fresno runs usually 35 to 40. Again, in 2017, we're up to 65. But you see, most of the time, we have 1,000 to 1,700 syphilitic cases. And the scary number is 97 of these are co-infected with HIV. So this year alone, we had some babies infected with HIV from a mom who is HIV infected. So that's kind of with the gonorrhea as well, that the last thing you want to be aggressive with this treatment is to prevent HIV cases. This is again from Fresno data, the HIV data in Fresno, that if you look at in 2017, as expected with the syphilis being at the peak, our cases were high. Most of the, every year we have about 20 to 30 cases of new HIV in Fresno County. Mainly, you could see there are mainly males. And it's unfortunate that some of these patients are at the AIDS stages where it's kind of too late. They mainly require hospitalization and they have poor immune condition at the time of diagnosis. Again, this is the HIV in Fresno. Majority are Hispanic. Majority also are MSM, which maybe I could think when it comes to not infected females and potential babies. And you have significant also number of these patients are very young. This is also Fresno data in 2013 to 2019. The most important number to look at this, it's 84 cases in that period of time has been infected with HIV at the time of the syphilis cases. So new HIV and syphilis cases. As I said, we have about 20 to 30 cases of HIV per year. But it's unfortunate that significant number of these patients with syphilis, they come infected with HIV at the same time. And if you look at the numbers for the PrEP, which has not been a popular thing to do in Fresno, which is also unfortunate, majority of these patients with syphilis, they're really not getting any HIV. So 245 out of the 260 something has no PrEP. And you're having significant number of these syphilitic patients are infected with HIV. So that brings the PrEP as very important way of preventing co-infection with HIV. Quickly, PrEP has two medications, Truvada and Descovy. They're the same medicine. Descovy usually, they're a combination of two HIV drugs. Descovy has a medication that's less, it's more friendly for your bones and your kidney. But Truvada is usually the traditional treatment that has been given. You take it every day, regardless if it's MSM or vaginal sex. They have one which is not FDA approved. It's on demand. You take mainly 2 tablets 24 hours before. This is mainly for somebody who knows, who's scheduled for a sexual encounter. And if you look at Fresno in California, you could see the big disparity between how many in different counties, if you go west or south, the PrEP so popular. And if you look at Fresno, it's just two Kaiser and just two other clinics that offer PrEP for their clients. And this is quickly one slide about the the hepatitis B vaccine. As you know, it's the 3 series for children. For adults, they came in 2 or 3 years ago with the new Heplisav, which is 2 vaccination a month apart. This is for hepatitis B. I will skip that part. The same thing with hepatitis C, who should be, nothing changed with the guidelines, who should be tested. And the last thing I want like about the HPV, and I thought this is mainly for pediatricians, but we see it also for internal medicine. If you're having your patient who has not been tested or has not been vaccinated for Hep B, try to push for Hep B vaccination. It's usually 3 shots if you're younger than 13 and 2 shots after that, but it's critical for HPV vaccine since the most common STD globally. This is a study that showed that it's the only study actually that showed that HPV vaccination does work over a period of time. In Sweden, it showed that when you give vaccination to folks, the risk of cervical cancer becomes significantly lower. Free STD sites in Fresno, there are different areas you could find these clinic sites if you want to refer your patient or partners for free STD testing. And I highly suggest to all providers, if you have a patient in the clinic, in the emergency room, upon delivery, and they have a positive RPR, give us a call. These are the numbers. Mainly, we help you if the patient had prior RPR testing done, if the treatment was done somewhere. Sometimes knowing the history of what testing and treatment has been done could save the baby and mom for unnecessary treatment. And many times also, it could promote, urge you to treat these patients because prior testing or treatment was inadequate. Many times when you look at snapshot of a positive RPR at one time, it doesn't really tell you anything. You have to look at the prior history and treatment to determine if treatment is needed or not needed. So these are the 2 phone numbers for the working hours and for after hours or weekends. So that's my presentation, and I'm open for any questions.
Thank you, Dr. Al. That was amazing. So much good information. We will archive this lecture so people can go back and visit it. But let's open it up to see if there's any questions while we have you on the chat. So someone's asking the difference between, I think, the penicillin and the bicillin LA. Is that something you can explain?
So, you know, the penicillin, there are 2 forms. So benzathine penicillin is long-acting penicillin. A few years ago, there was another form that was not indicated. So only the LA is the one advised by the CDC or CDPH. So yeah, the bicillin LA is the benzathine penicillin, and this is the only one that you should treat your patients with. If you don't have that form available, just give us a call, and many times we deliver the medication to your clinic if needed. If you have fridge and so forth to keep it stored until the client comes in for treatment.
Okay, sounds good. Any other questions for Dr. Al? All right. Well, thank you so much. We really appreciate everyone's time today, and especially Dr. Al for this excellent presentation. I think I speak on behalf of our whole medical community to say thank you. We appreciate everything you've been doing for so many years. We appreciate your hard work during the COVID response, and now really highlighting the issues related to sexual health and sexually transmitted infections. We know this is something, just like COVID, everyone is going to need to come together and share best practices, and hopefully we can make some progress and get off some of the state's top 10 lists. We want to be famous, but we don't want to be famous for our STDs. So we're really prioritizing what we can do to help curb this epidemic that we're experiencing here locally. And with that, I think we can go ahead and adjourn unless there's any other questions or comments. I know there was a question in the chat about COVID-related workplace screening. And the short answer is we're still waiting for OSHA to come out with new guidance. And I think after that, it'll be really clear what's actually required for workplace, everything related to COVID, but especially temperature screenings and things like that. So we'll discuss that next time we meet, hopefully next week. All right, thanks everybody. Take care. We'll get this posted up on YouTube and send out the link. Thank you. Thank you, Sim. Take care. Bye. Thanks, Dr. Al.